Good evening, everybody. Welcome to this evening episode of Pursue. Today we have Pursue O, which is liver and GI pathology, and we are streaming live from Kuwait City via Kolkata. And today we have the continuation of the small GI biopsies and polyp, and today is the session for polyps. And we have with us Dr. Rajaguru, who is a postgraduate from PGI Chandigarh at DNB, a specialist pathologist at Alsalam Hospital, Kuwait. A very reputed pathologist with interest in GI and liver pathology, is an expert in liver and GI diseases with multiple international publications related to GI and liver. Before I ask him to speak on this topic, which is actually a continuation session 3, I would request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Rajaguru, sir, please share your screen and let us start.
Good evening, sir. Thanks for the introduction.
Yeah, good evening.
Yeah. So, good evening, everyone. So, this will be my last session. So, last time we had seen about the approach to the small GI biopsies, and now we'll be seeing about the approach to GI polyps. I hope I'm loud and clear.
Absolutely loud and clear, and we can see your presentation right clear. So please go ahead.
Fine, sir. So I'll go ahead.
Fine. Yes, sir, please.
Yeah. So in general, the polyps of the GIT are divided into epithelial, hamartomatous, inflammatory, heterotrophic polyps, mesenchymal polyps. This is on the whole. So we'll be not going in particular types of what I've described. So we are going to see something about the approach. So mainly the gray areas will be covering about, and some of the new entities we'll be seeing about. So in the stomach, the polyps of the stomach are basically divided into those arising from the foveolar epithelium and those arising from the glandular component. So the foveolar epithelium, it can be of the hyperplastic type or the inflammatory type, and the adenomatous type. The adenomatous type might be intestinal or foveolar, and the polyps arising from the glandular component. The main important will be the fundigland polyp, which is the commonest polyp, and then followed by other rare types of polyps like the gastric glandular adenomas, that is the oxyntic gland adenoma, when it is chief cell predominant. These can also show a parietal cell predominance. And then with mucous neck cell type predominant, the pyloric gland adenoma, or it can be of the mixed type with both the mucous neck cell type with chief cells, also with the foveolar epithelium. So this is a basic classification of the polyps of the stomach. So without wasting much time, we'll go to the important polyp in the stomach, that is the hyperplastic or inflammatory polyp. This is a low power image showing marked foveolar hyperplasia. The foveolar epithelium are dilated and closely packed, and there is no ulceration seen here, but you can also find lots of ulceration. These polyps are usually seen in the antrum. As you know, the most common cause of chronic active gastritis is H. pylori. So hence these polyps are seen in the antrum. These are polyps which are basically happening due to hyperplastic regenerating mucosa. And in the body, it can be seen following autoimmune gastritis. So the other areas also showing marked edema with hyperplastic foveolar epithelium. Again, the same you can see over here. One thing to note about is that you see a lot of changes in the nucleus over here. The nuclei of these foveolar epithelium are looking stratified. And though I've not put a high power image of this, we're showing a lot of vesicular chromatin with nuclear prominence. So it is not uncommon to find reactive changes in a hyperplastic polyp. But what we see here is that the nuclei of this foveolar epithelium, which is seen towards the base of the foveolar epithelium, are looking more bluish, whereas if it comes to the surface, it is more pinkish. So this is called surface maturation, which is seen in a reactive or a regenerative atypia, whereas it will be absent in a dysplastic epithelium. So this is what it is, and there are more differentiating features which I'll be talking about it later. So basically, I wanted to ask the audience the diagnosis and what are epithelial changes, which I've already discussed. And the main important thing to point out is that differentiating a juvenile polyp from a hyperplastic or inflammatory polyp in the stomach as well as in the colon is going to be very difficult. If it is a pediatric patient, in the stomach especially, it can be, and if it's a part of a polyposis of the GIT, then you can diagnose it as a juvenile polyp, because morphologically, histomorphologically, it is going to be very difficult to differentiate both of them. Subsequently, we'll be talking more about that. And there is another case which is similar to that, a 27-year-old male who's presented with a colon polyp, and the photomicrographs are like this, low power image and the high power image, where you see the surface ulcerated with the crypts which are looking hyperplastic, with a lot of inflammation in the lamina propria, many of them showing intra-crypt abscesses, that is, crypt abscesses are seen. So, if I ask a question, is it an inflammatory polyp or a juvenile polyp? It's not possible to differentiate on histological grounds. We need to rely more on the endoscopic findings and the age of the patient. If the patient happens to be a middle-aged adult, or like if the pediatric patient, we lean more towards the juvenile polyp. And if the endoscopy is completely normal, or by chance if you have a biopsy from the non-polypoidal mucosa which is not showing any inflammatory change, then it is most likely a juvenile polyp. If not, it is better to coin them as a inflammatory polyp, which can be seen in relation to many of the inflammatory conditions of the colon, and in the stomach it is called hyperplastic polyp in relation to the gastritis that may be H. pylori related or autoimmune gastritis or any other gastritis for that matter. So as I told, history is very important. You have to do a background check. In the stomach, you have to look for H. pylori, mainly in a hyperplastic polyp. The most common cause being H. pylori gastritis, so have to look for that. And the inflamed non-polypoidal mucosa and the age of the patient is important. And in the colon, like inflammatory bowel disease, ischemic colitis, diverticuli, any other inflammatory pathology is important. So this is about that. And in the stomach, there are various type of polyps which are going to show mostly a similar kind of histological changes. So I've enlisted the differentiating points and how we can differentiate them. As I said, the juvenile polyp and the hyperplastic polyps are going to be difficult, except for the clinical history. There is another condition called the Menetrier disease. It's protein losing condition, where you have a hyperplastic foveolar epithelium, where it might appear endoscopically a polypoidal lesion. Usually they involve the body and the fundus, and they diffusely involve that area, and they spare the antrum, but certain cases might show a polypoidal appearance in a localized way. So might cause confusion for the clinicians whether it's a polyp or not. But here I'll show you the histological image. There's that the foveolar epithelium again will be hyperplastic, but the gland to the stroma ratio is markedly increased compared to the hyperplastic polyp or the Peutz-Jeghers polyp. here the gland to the stroma is increased and the glands appear packed, and the hypoplastic foveal epithelium appear corkscrew in appearance. He can see them closely over here as well. The important point is that you might get confused whether the hypoplastic foveal epithelium, um, maybe you might have a doubt if you will have a difficulty in differentiating from a reactive gastropathy. But the answer is no, because the foveolar mucin is not attenuated in the case of menetrius disease. It looks hypoplastic and thickened. Whereas in a reactive gastropathy, there will be loss of this foveolar mucin, and the epithelium looks more simplified and attenuated. So in that way, you can differentiate, and definitely the endoscopy is going to be different from in a case of a reactive gastropathy. So histologically, again, you might see some smooth muscle fibers which are playing in the lamina propria, which might mimic a Pusch's polyp, but again, you are not going to get the arborizing, branching tree-like fashion of the the muscle fibers in a Pusch's polyp. It is going to be completely different. And in Pusch's polyp, differentiating it from a juvenile polyp is not that very difficult, because here you have this prominent smooth muscle fibers which will be in a branching tree-like fashion, which will be separating these glands and the foveolar epithelium in between, and they are going to reach right up till the surface epithelium, till here. And whereas in a hypoplastic or a juvenile polyp, the stroma is going to be markedly edematous. So there is not going to be much of confusion differentiating them. So this is all about the hamartomatous and the inflammatory polyp in the stomach and the histological differentiating points. I hope it is clear. So the hypoplastic polyp may progress on to an adenomatous type with might show evidence of dysplasia and progress on to adenomatous type. And as I said, the main important thing is to differentiate dysplasia from a reactive atypia, as dysplasia is something to be reported about, and reactive atypia don't have to say anything. And in dysplasia, you will have mainly the architectural complexity, which is seen more common with the high-grade dysplasia than with the low-grade dysplasia, where you might get more of cribriform glands, back-to-back arranged glands, and irregularity of the glands. And as I said, there will be lack of surface maturation. The foveolar epithelium towards the base and as well as the surface is going to show similar kind of changes, with lots of nuclear stratification, atypia, mitosis, and loss of polarity will be something towards the high-grade dysplasia. A moderate to marked pleomorphism might be seen. Atypical mitotic figures will be seen in a dysplastic change. Whereas in a reactive atypia, as discussed earlier, we will have surface maturation. The nuclei are going to be enlarged, but there's not going to be a pleomorphism because they are going to be uniformly enlarged. And another important thing which is to be noted is that there's going to be marked cytoplasmic mucin depletion, with that particular change, it will be very easy to say that it is a reactive atypia. And nuclear hyperchromasia might be seen. The chromatin might appear vesicular. Nucleoli might be prominent, but still, with the overall changes, what we see, it will not be very difficult to differentiate from a reactive atypia from a dysplasia. And whenever you have a lot of inflammatory cells associated, particularly the neutrophils, we might not be able to confidently call it as a dysplasia. So it is always better to take a step back and say might be this is a reactive change and not dysplasia when it is associated with significant inflammation. But if the nuclear changes are marked compared to the degree of inflammation, still it can be a dysplasia. So these things have to be kept in mind. So going on to the gastric adenoma, so you have four types of adenomas in the stomach. The intestinal type of gastric adenoma, the gastric foveolar type of adenoma, where the epithelium is going to just look like the gastric foveolar type of epithelium, and the pyloric gland adenoma and the oxyntic adenoma. So starting with the intestinal type of adenoma, it is usually associated with hypoplastic polyp or chronic active gastritis showing intestinal metaplasia, and that is that the background mucosa is going to be inflamed, and the histomorphology is just going to be similar like that of a colonic tubular or a tubulovillous adenoma, with the pencillinate nuclei which are elongated with maintained polarity in a low grade dysplasia, whereas in a high grade dysplasia you're going to see a lot of loss of polarity and architectural complexity. IHC wise, MUC2 will stay positive, and there is a high risk of progression to malignancy. So this is about intestinal type of adenoma. Then is the foveolar type of adenoma. As I said, it's going to just look similar to that of the normal foveolar epithelium. The only thing which we will have to keep in mind is that the nuclei are going to be crowded, kind of a stratified, but they are not going to be oblong and elongated as we see in an intestinal type of adenoma. They are going to be more rounded and show prominent nuclei. So the cell with which we can compare it is the lymphocyte in the lamina propria. They are usually 3 to 4 times the size of the lymphocyte in the lamina propria. If they are of that particular size, then we are dealing with something like a foveolar dysplasia. So the foveolar dysplasia is usually seen with a normal gastric mucosa, that there will be no inflammation and no intestinal metaplasia. And with the figure here, you can see that the apical mucin is very well demonstrated with the PAS positivity. So this can help in differentiating from a intestinal type of adenoma. It is important because the risk of progression to malignancy is negligible in a foveolar type of dysplasia compared to that of an adenomatous dysplasia. So it is like it is better to report the type of dysplasia which you are seeing, type of adenoma which you are seeing, whether it is a foveolar type of adenoma or an intestinal type of adenoma. But definitely high grade does have significance, but low grade doesn't have much of significance. The nucleus will be, as I said, 3 to 4 times the size of the lamina propria lymphocyte. In high grade, they will show prominence of nucleoli and the glands will be more crowded. And MUC5AC, MUC5AC will be positive in these adenomas. MUC6 will be negative. So MUC6 will be useful in the other type of adenoma, which we'll see now. Then is the pyloric adenoma. Pyloric gland adenoma can be seen anywhere in the GIT, starting from the esophagus, gallbladder, the pancreas, even rarely in the colon, the bile duct, in the duodenum, anywhere. So they are associated with autoimmune gastritis, particularly with that showing pseudopyloric metaplasia. Can also be seen with the H. pylori gastritis and associated with familial adenomatous polyposis. They show GNAS and KRAS mutation, both the sporadic ones as well as the familial adenomatous polyposis ones. Both of them show GNAS and KRAS mutation. They are typically PAS negative, not like that which we had seen the foveolar type of adenoma where we saw the apical mucin. So these are typically PAS negative and they are MUC6 positive and MUC5AC negative. So you can have mixed types where you can see foveolar type with pyloric adenoma. So they can undergo malignant transformation also. So I'll show the image where you can see this kind of packed glands. They do not look like the fundic gland adenoma. These should not be confused with the fundic gland adenoma. gland adenoma. They are lined by this typical low-cuboidal epithelial cells with the ground glass appearance, as what they are described. That is, they are showing abundant eosinophilic cytoplasm and well-round small nuclei. And the dysplasia might be low grade or high grade, and these can progress on to carcinomas. These are typically MUC6 positive. So the main thing is that these are to be differentiated from oxyntic gland adenoma, mainly because of the fact that the molecular genetics is a bit different between them, and morphologically they are also quite different in from a pylori gland adenoma. That is, oxyntic gland adenoma shows anastomoting glands with similar kind of the cells lining them, but they are similar to that of the chief cells with a amphiphilic cytoplasm. But they can also show parietal cell type of epithelium also. These are similar. One study has shown some association with genus mutation, but WHO has mentioned that only 19% show genus mutation, whereas around 30% show mutation of the genes involved with WNT beta catenin signaling pathway. This is actually considered by the Japanese pathologist to be an early gastric carcinoma, but the Western pathologists do not consider it as an early gastric carcinoma unless it invades the submucosa. And histomorphologically, as I told, they are composed of anastomoting tubules and cords, mainly of the chief cells, with pale basophilic cytoplasm, basophilic or amphiphilic, mainly those with the morphology of the chief cells of the gastric glands, the oxyntic glands in the fundus of the body. And they might show mild nuclear atypia. Sometimes they have these parietal cells. Parietal cells are going to look more eosinophilic. So whenever it's basophilic or amphiphilic, they are chief cells, which are the predominant type, and eosinophilic when it is composed of the parietal cells. So they are also MUC6 positive. It is only on morphological basis that we can differentiate between an oxyntic gland adenoma and a parietal cell adenoma. So here oxyntic gland will show the anastomosing cord-like pattern, whereas the pylori gland adenoma will show isolated glands which might be dilated and packed with the typical ground glass cytoplasm. So these are the morphological points differentiating them, and both have can progress on to carcinoma, but it is more common with the oxyntic type of adenoma, oxyntic gland adenoma. Around 60% progresses on to gastric carcinoma, and it is considered as a fundy gland type of gastric adenocarcinoma. So this is the MUC6 IHC, which is positive in both oxyntic gland adenoma and the pylori gland adenoma. MUC5AC, as you see, will be staining only the foveolar epithelium, which is seen over here, but the glands will be negative. So this is a very simple fundy gland type of adenoma, where you can see this dilated glands, which will be lined by this mucus neck type mucus cells, and then the chief cells and the parietal cells. So it is a type of hamartomatous polyp, which can be sporadic or familial. In sporadic cases, they are usually single. Whenever it is multiple, they can be familial, and the multiple cases can be associated with familial adenomatous polyposis. It's always better to check for a familial adenomatous, or to ask for history, or to examine, to do an endoscopy of the colon when there are multiple fundy gland polyps, and mainly those with dysplasia, which are seen in young patients particularly. In the familial cases, they can be associated with colon polyps also, but they can be isolated gastric polyps alone, fundy gland polyps alone. They have beta catenin and APC mutation. Both the sporadic and the familial type both have beta catenin APC mutation. The sporadic ones are associated with proton pump inhibitor therapy. Then going on to the polyps which are seen in the small bowel, the first will be the duodenal gastric heterotopia. They might appear as a polypoidal lesion on endoscopy or just like a elevated lesion. Usually they are seen in the D1 part of the duodenum, where you see here the foveolar epithelium is seen with the oxyntic type of glands in the lamina propria. So this is called duodenal gastric heterotopia. As you know, heterotopia is just the presence of normal tissue at a foreign site, and they are not associated with H. pylori, so they are not part of the peptic ulcer syndrome. And they have a debated association with the proton pump inhibitor therapy and hypergastrinemia, still not known. They're usually not symptomatic and they don't require treatment. They are incidentally biopsied while doing an upper GI endoscopy. And when you find this, it's better to report duodenal gastric heterotopia from the D1. So heterotopia with pancreatic tissue can be seen anywhere in the GIT. It can be a heterotopia or a metaplastic change. That is all about. You can see only the acini, or you can see the acini with the ducts also. Then is the Brunner's gland hyperplasia or hamartoma. Hyperplasia is just that the glands are very hyperplastic and seen even in the lamina propria, as you see over here, and multiple lobules of these benign looking glands, which are going to look nodular on endoscopy. But in a hamartoma, you might see a lot of fat, which are not normal for this particular site, and you might see some smooth muscle fibers also. So that if those are present, you just call it as a Brunner's gland hamartoma. If you don't find them and you find only glands, you call just as a Brunner's gland hyperplasia. That is the only difference. Then going on to the inflammatory polyps, which can be seen in the small intestine or the large intestine, the colon. So in the small intestine, we usually come across the inflammatory pseudopolyps, mainly with the Crohn's disease or any other enteritis. But in the colon, we have a special type of polyp which is associated with mucosal prolapse. That can be the polypoidal SRUS, the prolapse type of inflammatory polyp, inflammatory cap polyp, where you can have the surface which is ulcerated, formed by inflammatory granulation tissue, and a well-formed neutrophilic exudate on the surface. So that is just a morphological entity. Then the inflammatory cloacogenic polyp, as the name suggests, it is seen in the anorectum. And then the inflammatory myoglandular polyp, which is going to show a lot of muscle fibers in the stroma. It will be difficult to differentiate from an SRUS, but still there are certain features with which you can differentiate, and they are usually seen in the colon and rarely in the terminal ileum. This is an example of inflammatory polyp, which was seen in a case of an ulcerative colitis, where you see this crypts to be hyperplastic with some inflammation in the lamina propria. Again, you are seeing some reactive changes. This is not a part of dysplasia. And the normal muscularis mucosae, which is seen over here. And in certain cases, the inflammatory polyp might be composed only of inflammatory granulation tissue. I think you will all be knowing that inflammatory polyps are just the regenerating mucosa between the ulcerated area, and that polypoidal regeneration can show ulcer or might not show ulcer. So the main thing, as we spoke earlier, that inflammatory polyps are difficult to differentiate from juvenile polyp, and the difference is that an inflammatory polyp can occur in any age and can be associated with IBD, infectious colitis, necrotic enterocolitis, ischemic colitis, and diverticular disease associated colitis. It is just a polypoidal regeneration of the intervening normal mucosa with or without ulcer. Mainly in a large polyp or those with associated with IBD, you will have to look for dysplasia. And in certain cases, the stromal cells of the inflammatory polyps might show some atypia. They should not be confused for a malignant change. And juvenile polyps are usually seen in children and young adults. There will be no inflammation of the colon endoscopically, and fortunately, if they are sampled, the non-polypoidal mucosa is not going to show any inflammatory change. Histologically, it is difficult to differentiate, and you will have to rely on other parameters to call it as juvenile polyp or an inflammatory polyp. And the juvenile polyp, whenever it is a large polyp or a part of a syndrome, then you will have to look in for dysplasia. So the next is the difference between prolapse type inflammatory polyps, which I had just briefed out, between this and the Pusch's polyp, because both are going to show prominent smooth muscle fibers in the stroma. As you all know that the Pusch's polyp is a hematomatous polyp, and it can be seen anywhere starting from the stomach, the small bowel, and the colon, and they typically show the arborizing tree-like architecture. Later, subsequently, we'll be seeing the images also. The epithelium is just going to be similar to that particular site, be it stomach, small bowel, or the colon. And these pockets of these epithelium are just going to be divided by slender branching tree-like fashion of these smooth muscle fibers, and they're not going to divide them with thickened muscle fibers. So with that, you can differentiate from a prolapse type inflammatory polyp, where you will see the stroma showing replacement with a lot of muscle fibers compared to that of a Pusch's polyp. So the crypt packets will be divided by thick muscle fibers in a prolapse type of polyps, whereas here it will be usually the slender ones, and these muscle fibers will reach up to the surface of the epithelium. In a Pusch's polyp, you have to look for dysplasia as well. So we're going with the histological image of an SRUS or a polypoidal SRUS. You see this the stroma to be replaced with a lot of these the smooth muscle fibers, and this disorganization of the crypt architecture with some inflammation in the lamina propria. So this kind of thickened muscle fibers are not going to be seen with the Pusch's polyp. This is a case of inflammatory myoglandular polyp, where you see this packets of these crypts are separated by the intervening thickened muscle fibers. You can very well see this on higher magnification also. There is lots of these hemorrhage and some inflammation going on in the stroma also. Next is the image of the Pusch's polyp. I think you can very well appreciate the blueness of this polyp. So when you're going to take the slide and put it under the microscope, before seeing under the microscope, if you just have a look at the slide, any hematomatous polyp is going to look blue, whereas an inflammatory polyp like this with a lot of stromal muscle fibers is going to look a lot pinker. So with that itself, you can make a diagnosis, and then when you are going to see it under the microscope, you are going to classically see this kind of branching tree-like architecture of these muscle fibers, which are going to reach till the tip of the epithelium. This is a case of a Pusch's polyp arising from the small bowel. So it just has the morphology typical of that particular site. So I'm going to show a case of different polyps in a teen, mainly in the colon. So here you can see, this is a polyp which is showing hyperplastic crypts, which are irregularly dilated and branched. You see some amount of inflammation, chronic inflammation in the lamina propria. So this is a juvenile type of polyp. So as I told, this is a teen, so don't have to confuse it with the inflammatory polyp. This is going to be a juvenile polyp, and this is another polyp where you see this epithelium is fine, but here you see some nodular proliferation of bland spindle-shaped cells. This is a juvenile polyp. This is a benign Schwann cell hamartoma in the colon. And then another polyp where you see a lot of the spindle cells in the lamina propria, and you see scattered ganglion cells. This is a ganglioneuroma. So this is a part of Cowden syndrome. So here you have it as a part of Cowden syndrome, and the Cowden syndrome affects the skin, the breast, endometrium, and the thyroid. Then the polyps are similar to juvenile polyp, but the intervening areas show dilated crypts. So this is how you differentiate it from a juvenile polyp. Before moving further, is there any questions, sir? Dr. Nadi? Should we? Hello? So should I move on? Okay, fine. So maybe we can cover the questions at the end of the topic. So as we see, this is a type of a hamartomatous polyp, a
Yes, there
particular
are
syndrome, the
questions.
Cowden.
There are quite a few
Okay,
questions, and
okay.
I have sent you on your WhatsApp, because if you want, I can read them
Hmm.
out to you.
Yes, sir. Yeah.
Yeah, I think it's best that we finish it at the end, because there are quite a few,
Yeah.
and
Okay.
maybe some more will be added.
Okay, sir.
Okay, fine. I have sent it
Okay.
on to your WhatsApp, so you can have a look.
Yeah.
If you want, I
Okay.
can read them out to you.
Okay. Fine, sir. Okay. Then we are going next to the
Yeah, please
concrete
continue.
Canada
Yeah.
syndrome. Concrete Canada syndrome, the polyps are going to be similar to the polyps in the Cowden syndrome or the juvenile polyp. They usually affect the middle aged. So this is a table showing the different type of hamartomatous polyposis syndrome and their association with lesions elsewhere in the body, the skin, the breast, and the thyroid. So we can go, means I'm not going into detail of that. So quickly moving on to the next topic, the epithelial misplacement, which can happen in the polyps, which can occur in anywhere in the GIT, starting from the stomach, the small intestine, the colon. So whenever it is associated with inflammatory lesion, they are called as gastritis cystica polyposa, enteritis cystica polyposa profunda, and colitis cystica polyposa profunda. Basically, if it is a polypoid lesion, it is called polyposa. If, so this is basically with those which are associated with inflammatory conditions of the GIT, and epithelial misplacements can also occur with other type of polyps like a hamartomatous polyp, inflammatory polyp, adenomatous polyp, or the serrated polyps. So it's very important to differentiate mainly when it comes to an adenomatous polyp. These epithelial misplacements can mimic malignancy. So there are features with which we can differentiate these misplacements from the true invasion which happens in a malignancy, and thereby avoiding, you know, the overcall of a malignant lesion. So this is a case of an inflammatory polyp in ulcerative colitis. Had presented with giant polyposis, where you saw a lot of these epithelial islands which got misplaced in submucosally. And what you see over here, the epithelium is hyperplastic and it is surrounded by a good amount of the lamina propria. Here again, you see there's a lot of lamina propria, and the glands might appear dilated with mucin in them. Again over here, but what you see over here is that the epithelium is more or less benign, and they are uh, like lined by cells which are going to look similar to that of the surface epithelium. So they are not malignant appearing, so it's easy to differentiate. Here again, these epithelial misplacements which are lined by this benign looking epithelium, and they are surrounded by a good amount of lamina propria over here. In this case, this is actually an invasive adenocarcinoma where you see this kind of architecturally abnormal and cytologically abnormal cells which are invading the bowel submucosally, which is associated with a lot of desmoplasia which is going on. So the differentiating feature is that the architecture is going to be smooth and rounded and lobular in case of an epithelial misplacement, whereas in an invasive carcinoma, it is going to be irregular and tortuous. There might be mucus cyst and extravasated mucin in epithelial misplacement, but the strips are usually show a rounded, strips of epithelium which is going to be lining these mucuses. They are not going to float inside the epithelium, and in a misplaced epithelium, basically it is due to either a torsion or an ischemia or an ulceration. So you might have a lot of hemorrhage with hemosiderin macrophages in the surrounding the misplaced epithelium, and you always see a lot of lamina propria around the misplaced epithelium. If the epithelium happens to show dysplasia, they're going to look similar to that of those which are looking on the which are present on the surface. So invasive carcinoma, it mainly we have difficulties when it is associated with adenoma on top. Here we'll see a lot of desmoplasia, single cell infiltration. There is not going to be any lamina propria surrounding that. The mucin pools are going to be irregular with the malignant cells which are floating within the mucin pools. So these are the main differentiating features. So then I'm going to show a case of a 41-year-old male with a large pedunculated polyp in the sigmoid colon. Piecemeal polypectomy was done. So this is the low power histology of that particular case, where you see this colonic epithelium, the lamina propria, to be completely normal, and submucosally we are seeing some lesion, a lesion which is rich in vascularity. Here you see a lot of this kind of bland proliferation of spindle to oval to spindle shaped cells, and this typical onion skinning around these vessels, and you see a lot of eosinophils also. A similar case in the stomach, which had presented as a gastric polyp. Again, you see there is a lesion which is arising submucosally and is seen infiltrating the lamina propria. Again, you see a lot of these bland looking cells, round to oval, with a lot of eosinophils and typical localization around the vessel. Any answer for this, sir?
Not yet.
Not yet? Okay. Shall I move on?
Yeah, please move on. Yeah.
Okay. So this is a case of inflammatory fibroid polyp. Yeah. So next is a 44-year-old female, a periampullary mass in this particular patient, where you see there is a lesion in the submucosa, which is composed of this. Um, and on a higher magnification to show these epithelial looking cells with intervening spindle shaped cells. And here you see the cells which are with abundant cytoplasm, peripherally located nucleus. These are different from those particular cells. When IHC was performed, these epithelial cells were positive for pan cytokeratin, chromogranin positive, S100 positive in the those cells with abundant cytoplasm. These are mainly the ganglion cells. This is a case of gangliocytic paraganglioma, which is usually seen in the ampullary region. So I'm quickly going on to the ESD and the EMR, endoscopic mucosal resection and endoscopic submucosal dissection. So for gastric tumors, they are usually done in cases which are PT1A, that those which are showing the lamina propria and the muscularis mucosae invasion only. So if they are going to spread submucosally, they are not going to be done. And endoscopic submucosal dissection is that, as the name suggests, there will be a lifting agent which will be in the submucosa, and they are going to be dissected out. I have not shown the procedure because it's a general topic, so I'm just briefly describing it. So the polyp or the lesion on the whole is cut out from the submucosa, and a good amount of submucosa will be taken along with the lesion. In endoscopic mucosal resection, the lesion is going to be dissected out, which is going to have the base with the muscularis mucosae or a little bit amount of the submucosa. They are usually piecemeal. This is going to be usually a piecemeal technique, the endoscopic mucosal resection. Very rarely we get an intact whole specimen, whereas in an ESD, the specimen is going to be completely intact. And as I told, it is going to be performed in a gastric lesion for lamina propria or the muscularis mucosae invasion only. And they are done when the size of the lesion is less than equal to 3 centimeter mainly. And in the colonic lesion, there are different indications, mainly for the adenomas. EMR is preferred than ESD. For lesions which are larger, the ESD is preferred compared to the EMR. For rectal carcinoids, which is very small, less than 1 centimeter, they prefer EMR. If not, they usually prefer surgery because it might spread deep down. So the grossing for ESD and EMR, you're going to get a specimen which is going to be flat with the lateral margins and the mucosa on the top with the muscularis mucosa, the submucosa on the base. So we will have to ink the base and the lateral margins, fix it with the mucosa on top with a rigid support, and you have to make a photograph and adequately fix the section before, tissue before grossing. Excuse me. So we'll have to serially cut this tissue 2 to 3 millimeter intervals parallel to the long axis, and entirely embed them to look for any invasion if there is, and to look for the distance from the margin, be it the base or the lateral margin. So the histopathology will be to identify the tissue present, the size of the lesion, histological type and differentiation, grade of dysplasia, the margin status, and the measurement of the distance between the margin and the tumor cells, the depth of invasion, lymphovascular and perineural invasion, presence of any other pathology. So for pedunculated and sessile polyp, you have different type of classification systems. You have for the pedunculated polyp, you have the Haggett system of classification. For Haggett, the main thing, as I told, the Hadget is used for the pedunculated polyps. So as you see here, the polyp and the changes of the polyp is ending here, and you have the stalk of the polyp over here, and this is the head of the polyp. So this is the junction between the head and the stalk of the polyp is called the Hadget line. So here you can see it very well. This is the Hadget line, which is going to be the line between the head of the polyp and the stalk. So this is very important. I will tell you why. So as you see here, level 1 is invasion through the muscularis mucosa, but limited to the head. Level 2 is invading the neck of a pedunculated polyp. So you have it till here, till the neck. This is level 2 over here. And then level 3 is invading the stalk of a pedunculated polyp. So from anywhere from here to here will be 3. And then when it invades into the submucosa below the stalk, so that is level 4. So the importance of the Hadget line I will tell you. For a flat polyp, a sessile polyp, you have the Kikuchi classification. Basically, they are divided into SM1, 2, and 3 based upon the level of invasion. If it is occupying the upper 1/3, it is level 1. Level 2 will be middle third, and level 3 will be the lower third, just above the muscularis propria. So the problems with the ESD and EMR is that the muscularis mucosae may be disrupted by ulceration or tumor invasion. So we might not be able to see a proper muscularis mucosae. So we might not be able to measure the actual depth of invasion, because in the lesions, the tumors of the colon, the invasion beyond the muscularis mucosae is considered as T1. So if it is going to be an intramucosal carcinoma, it doesn't have, means it is still called TIS. So only invasion beyond the muscularis mucosae is called T1. So if the muscularis mucosae is disrupted or ulcerated, the measurement of the depth of invasion is going to be difficult. So in such a case, when you have a sessile polyp and you have a disrupted muscularis mucosae, the tumor thickness, the entire thickness has to be measured, and it is the PT1 with the tumor thickness is the measurement of the polyp. Whereas when the muscularis mucosae is present, the tumor thickness is measured from the muscularis mucosae till the maximum depth of invasion. That will be the distance. And in a pedunculated tumor, I told you about the Hadget line. So just between the neck and the stalk of the polyp. So from that, you have to measure the invasion. Suppose if a lesion is involving only the head of the polyp, there is no point in measuring the thickness of the distance of the lesion invasion. Basically, it has to invade beyond the Hadget line. So those lesions which are involving beyond the Hadget line, that is the level 2, beyond level 2, it will be considered as invasion, and only those have to be measured. So that will be called T1 stalk invasion, and with the measurement in thickness, in microns, you have to give the measurement. So this is a photomicrograph showing adenoma for which an ESD was done, the lateral margin which is inked, and here you see the invasion which is going beyond the muscularis mucosae. There might be many artifacts which might be seen, particularly in a EMR specimen or an ESD. So I'll move on to another case, an interesting case of a 50-year-old female with a polyp in the sigmoid colon. So this was the history, and this was the specimen which we received. So here it looked like a normal colonic epithelium, with a big strip of epithelium, and right over here, it looked like a diminutive polyp on lower magnification. But when you go to the higher magnification and see, this did look like an adenomatous change, but the nuclear morphology was a bit more higher for a, a polyp or an adenomatous polyp. So the thought of doing deeper sections and went ahead and did deeper sections, and still the dysplastic changes were more prominent, and there was a lot of crowding of the glands, and still went further deeper. And this is, I think, the 20th slide, where I saw a lot of these cribriform glands with intraglandular necrosis and irregular, infiltration into the lamina propria with some desmoplastic reaction in the stroma. So this is a case of an intramucosal carcinoma. So it might look so diminutive is what I wanted to point out. And if in case you get a lesion like this, it is always better to do multiple deeper section to study the entire polyp. We might not know if this polyp is going to be seen invading the muscularis mucosa as well. In that case, it is going to be called as a PT1. And it is different from a high-grade dysplasia. High-grade dysplasia is going to show similar cytomorphological finding, but architecturally it is not going to be very complex as we see here, and there is not going to be much of desmoplastic reaction in the lamina propria. As we see, there is a lot of changes in this particular site compared to the lamina propria over here. So this is what I wanted to stress about. So moving on to the next type of polyp, the hypoplastic polyp. So you see a lot of serrations on in the surface epithelium, which is seen in the superficial part of the surface epithelium, but deep down the surface, the crypts do not show serrations. And here the bases of the crypts are looking more bluish with stratified nuclei and some mitosis. And that is, these are the proliferation centers which are seen in a hypoplastic polyp in the basis of the crypts and not higher up in the crypt epithelium. So this has significance, and mainly I want to stress out the point that these changes which are seen in the the basal part of the crypts should not be confused with the adenomatous polyp. The pathogenesis is completely different. So hypoplastic polyp usually involves the left colon, and they are usually less than 1 centimeter. As I told, the proliferation centers are confined to the lower portion of the crypts, and these are not to be confused with adenoma. As we see here, the mucinous epithelium, which is nicely seen over here, is reduced here with reduced number of goblet cells. So this might very well mimic an adenomatous change. So this should not be confused with that. There are two types of hypoplastic polyp according to the recent WHO: the goblet cell rich hypoplastic polyp, which is associated with KRAS mutation, which show less serrations, and the microvesicular type of polyp with BRAF mutation. Cells at the base of the crypts are microvesicular and tend to show elongated nuclei, crowding, and increased mitotic figures. This is what I was describing. And hypoplastic polyps with prolapse changes may show architectural abnormality with branch crypts. So these polyps, as you see, they can be usually seen in the left colon, and they might show some prolapse-related changes. In those conditions, you might get architectural abnormalities of the crypts, and these should not be confused with a sessile serrated lesion. And if they are associated with a prolapse type of change, you definitely will see some changes in the lamina propria, not the normal cellularity. It is going to show lot of these smooth muscle fibers in the stroma, and hence you can differentiate it from a sessile serrated lesion. So in a sessile serrated lesion, there are four important points. The crypts might show horizontal growth along the muscularis mucosae in an inverted T or an L-shaped fashion. Dilatation of the crypt basis might be seen, and to be noted is that the symmetrical dilatation alone does not qualify for calling a polyp as a SSL. It has to be asymmetric dilatation, as one crypt to be dilated compared to that of the other crypt. So this is what is about the dilatation of the crypt. The serrations has to reach till the base of the crypt, and there will be asymmetric proliferation. That is, the proliferation centers, which I had shown you over here, which is seen in the base of the crypts, will reach higher up towards the mid and sometimes even the upper areas of the crypts. So this is an image, low power image, showing architectural abnormality with kind of an an L-shaped morphology. There is dilatation and serrations even involving the bases of the crypts. So that is a sessile serrated lesion. So this is what is the new terminology. It is called sessile serrated lesion and not as a sessile serrated polyp. So this sessile serrated lesion might show dysplastic change, and this is dysplastic change where you see a lot of serrations along with dysplastic changes over here. This looks more of a dysplasia NOS type of category. I'll describe in the next slide. This is a dysplastic change in the same polyp. This is the same case where here you see a type of dysplasia, whereas here you do not see much of serrations, and a lot of these kind of goblet cells over here. This is more like an adenomatous type of dysplasia. If you give this slide to anyone, this particular focus to anyone, they might diagnose this as a tubular adenoma, but this area was part of this same polyp. So it's a case of a sessile serrated lesion with dysplasia, and MLH1 would be lost in the dysplasia which is commonly seen. I'll show you what it is. So there are totally four types of dysplastic changes which can be seen in a sessile serrated lesion. The dysplasia NOS, which is the most common type, the adenomatous type, the conventional adenomatous type, the serrated dysplasia, and minimal deviation change. So the dysplasia NOS is like what I showed you earlier. This is going to show a lot of nuclear stratification, nuclear atypia, with or without loss of polarity, and the adenomatous type is going to show changes which is going to be just similar to that of tubular or tubulovillous adenoma. Serrated dysplasia is similar. Is going to show atypia of the nucleus with rounded nuclei. Sorry for the spelling mistake. Prominent nuclei and increased mitosis. There will be reduction of the serrations, and the cytoplasm will appear more eosinophilic. And the MLH1 here is retained, microsatellite gene. It will be retained here. In a minimal deviation dysplasia, the cytoplasm appears more mucinous, and it will be similar to that of the gastric foveolar type of dysplasia. Hello?
Can I just interrupt? I mean, you have lost your screen.
Oh, you've lost my screen? Okay, should I log out and where did you lose
please don't just present again, please. Actually, somebody else has possibly shared his screen, and that is why Dr. Surpada Malik has shared his screen. So that's why your screen has just gone away. So please just share your screen. Requesting Dr. Malik not to share his screen, please.
So I'm not able to cancel that. Stop screen sharing. Okay. Uh, Sir, should he stop sharing before I do that? Okay, now I
You
can
share.
do it.
Please share. Yeah.
Okay. From where were you not able to get my screen, sir? From where should I
Just
start?
one slide. Just go one slide back. Just one
Okay,
slide.
is
Yeah,
this the
that's
one,
it. Yeah.
MLH one? Okay,
Yes, yes,
fine,
yes,
okay,
yes. Otherwise, everything was
okay,
fine. Everything was.
okay. So as we see here, I think I went from the dysplasia in a sessile serrated lesion.
Yes, yes,
So
yes.
this happened. This is a case of sessile serrated lesion with dysplasia. Uh, Photomicrographs from two areas. One was showing dysplasia NOS kind of change, and the other one was showing the adenomatous type of dysplasia. Uh, I think I went ahead and started describing about that. So the MLH1 IHC is showing loss of nuclear staining in the area which is showing dysplasia, whereas here the MLH1 IHC is showing retained nuclear staining of the antibody. So here, as I said, the sessile serrated lesion showing dysplasia is going to show a sharp demarcation. Like what you see over here, there is a sharp demarcation of the lesion with the sessile serrated lesion, and there are four types of dysplastic change: the dysplasia NOS, the adenomatous type of dysplasia, serrated dysplasia, and minimal deviation dysplasia. So serrated, mainly NOS is the most common type, and as you said, as you know that like it is not otherwise specified, and you're not going to particularly call it as any of those type. You're going to call it as a dysplasia NOS. Um, and here, serrated dysplasia is going to show atypia with rounded nuclei, prominent nucleoli, and increased mitosis. Main thing will be is that there will be reduction in the serration, and the cytoplasm is going to appear more eosinophilic. Mm, uh, and the MLH1 in this is will be retained. In an adenomatous dysplasia, it is just going to look similar to that of a tubular adenoma. Uh, and in a minimal deviation dysplasia, the dysplastic change is going to look similar to that of the gastric fovea type of dysplasia which we had discussed earlier. The cytoplasm is going to look hypermucinous with minimal atypia and high mitotic figures. This is a difficult diagnosis and only can be diagnosed with the IHC, that is a loss of MLH1. The polyp showing dysplasia might show heterogeneous changes, that is different type of dysplasia can occur in the same polyp as we had seen in that particular case. And MLH1 is lost in the most common type, the dysplasia NOS, and the minimal deviation type. They are not lost in serrated and adenomatous type. So henceforth that like if you do an IHC for MLH1, if it is lost, it means that it is dysplastic. But if it is retained, it does not prove that it is not dysplastic. So that is the thing, because serrated and adenomatous type both might not show MLH1 loss. So another important point is that you need not say that it is a low grade or high grade dysplasia like what you get in an adenomatous type of polyp. It doesn't have any significance because SSL with the dysplasia has the same surveillance, that is frequency, that is the endoscopic repeat endoscopy will be uh, mm, not performed on a different time interval. If it is a high grade or a low grade dysplasia, the follow up is going to be the same. However, if you find an intramucosal carcinoma, it has to be reported. but there is no need of saying whether it is a high grade or low grade dysplasia. We'll just have to see if dysplastic change is present or not. And if a fragment showing dysplasia does not show serration, this is a main important problem which we usually face. That is a container. That is, suppose we get a colon polyp. Usually we get polyps in the colon, and a single container might show 3 or 4 different type of different tissues in them, and the histology might show 2 or 3 different type of polyps. That is, one might be a hyperplastic polyp, the other might be an adenomatous polyp, the other might show a sessile serrated lesion. So we might be confused whether we are dealing something like a sessile serrated lesion with dysplasia, as sessile serrated lesion might show adenomatous type of dysplasia and other types of dysplasia. So in those particular cases, mainly the endoscopic report will really help. Like if it is a single polyp or multiple polyps. And other thing to be noted is that the same polyp, if it is showing serrations at one place and dysplasia at the other place, it is going to be of the sessile serrated lesion with dysplasia. If the polyp is going to show serrations without dysplasia, and a separate polyp is going to show adenomatous type of dysplasia, it is better not to call it as a sessile serrated lesion with dysplasia, and better to call it as a separate tubular adenoma, and this as a separate sessile serrated lesion. So I hope I'm clear. I'm not confused anyone. And another important thing is that, like, if in doubt, you can perform an MLH1, and if it is lost, it is going to prove that it is a sessile serrated lesion with dysplasia and not a adenomatous polyp. And then going on to the traditional serrated adenoma. This is a picture of traditional serrated adenoma, where you have the pencillinate nucleus, which is stratified with abundant eosinophilic cytoplasm. We have this lot of serrated appearance, which looks like that of a normal small bowel epithelium, where you have this kind of slit-like spaces, slit-like appearance, slit-like serrations, which happen in the normal small bowel also. So when it is kind of projecting into these are called ectopic crypts. So I will show you this in the next photograph, where you see this kind of ectopic crypts which are seen arising. These are nothing but the cross section of a slit-like serrations, which are seen in case of a traditional serrated adenoma. This is a classical morphology with abundant eosinophilic cytoplasm and typical pencillinate nuclei, which are stratified. So adenomatous changes can occur in traditional serrated adenoma as well. And as I told, these are large protuberant polyps, usually in the left colon, or flat lesions in the right colon. They have abundant, intensely eosinophilic cytoplasm with bland oval palisaded nuclei without mitotic activity. Slit-like serrations with ectopic crypts are seen, and the ectopic crypts presence are not mandatory for a diagnosis of traditional serrated adenoma. In certain cases, we might not be able to find them, and only few goblet cells are seen in the case of a traditional serrated adenoma. Adjacent precursor lesion like a hyperplastic polyp or a sessile serrated lesion can be found, and areas of dysplasia can be seen, like an adenomatous or a serrated type of dysplasia, be it a low grade or high grade, needs to be reported. So next we'll just move on, see a case of a gastric fundal polyp in a 40-year-old male. This is photograph of the slide. I did not have a gross image of the case, so I just clicked the photograph. So you see that the mucosa is seen here, and you see a polyp very clearly seen in the submucosa, which is bluish in appearance. And this is basically a spindle cell lesion in the submucosa. I have inked the deep margin, and here again you can see the mucosa, which is completely fine, and you see a circumscribed lesion in the submucosa, which is composed of spindle cells over here. And any diagnosis, because this is the last case from me and this is the last slide from me, any diagnosis from the audience?
Just let us wait because it'll take a half a minute
Yes,
for the YouTube people to see and respond. I don't see any response in the YouTube,
Okay.
so I think
Okay.
go ahead.
Actually, okay. So in this is just, we are not talking about of the GIT. So just it happened to be an interesting case and presented as a polyp endoscopically. I had shared this. So I think the doctor who had presented about the mesenchymal lesion would have covered about this. But as we all know that the most common submucosal lesion in the stomach is the gist, basically the spindle cell lesion. But what we see over here is some lymphoid aggregate which is seen in the wall of the this particular lesion, which can be seen over here as well. So this is a classical. We have some nuclear palisading also. This is a classical case of a gastric schwannoma. Definitely IHC for CD117 or DOG1 needs to be done for confirmation. So that's all from me. Thank you.
Wonderful. Dr. Rajaguru, I wish I can give you a standing ovation. Wonderfully presented. Excellent presentation. All your 3 lectures were so good. It's like writing a chapter in a book. No, so very well. And I am sure people who will view these, because many people have been viewing it, your first and second lecture, they will get a complete picture of small GI biopsies as well as such a wonderful presentation, and so nicely you have explained all the polyps, especially the complicated hyperplastic polyp with its new terminologies and how to handle them, when to call it dysplasia, when to call it adenomatous, especially many a times it is very common that you get multiple bits of the polyp in the same container representing different polyps, all showing different histology, and then how you handle that, do with it. Very, very nicely presented. You are really a very good teacher and a very knowledgeable person. I mean, for that, I mean, there are a lot of questions, mostly theoretical. I have forwarded you on your WhatsApp. If you feel comfortable answering them now, you can answer them now. Or if you want, you can answer them on the Telegram, whichever, because you have you've been continuously speaking for more than 1.5 hours. So you must be really tired. So just go through them and let me know if you want to add them, because most of them are mostly theoretical, role of EPV in gastric adenomas and all that.
Yes, sir. I guess it is EBV, I guess. I think Epstein-Barr virus. Or what is it like? Epstein-Barr virus, is it, sir? I think, as you said, it is more or less, like, more likely theoretical, and, like, I think it's not related to the topic I'm speaking about.
Yeah, I have sent you it on your WhatsApp, because you take your time to answer that. If you feel, you can answer them in the Telegram. Dr. Pranab Kumar,
that will be right.
And other people can benefit from them. It was wonderful, Dr. Rajaguru. It's an honor for me to go through your all three lectures and listen to that. So wonderfully done. Excellent presentation. Very
Thanks a
nicely
lot, sir.
done. Anybody in
Always a
the
pleasure.
audience would like to comment? And
Sir, I just want to ask, like when I was talking about the cell-saturated lesion with dysplasia and the multiple punches taken from different polyps in the colon without a proper clinical history. I was talking about that. Was I clear about that? Because I
clear. I mean,
thought if
everything
I had.
very that part. That is
Okay.
it. And went so comfortably that it was very clear
Okay.
as to what one should do and what actually it means. So that part is very clear.
Okay. Okay. Fine.
So we'll just wait for anybody in the Google Meet if anybody wants to make a comment or anybody wants to
Fine. Sir, I would
any
like
question.
my head, Dr. Anand Patania,
Yeah,
to
answer is
give
here.
a comment. Anand sir
Anand
is
sir,
here.
yes, yes,
Dr. Nadim sir, first of all, thank you to you for organizing such wonderful lectures. And
so my
Dr. Rajaguru sir, the three lecture series were awesome. uh,
yeah,
it's
Thank
a
you, sir.
it's a treat to listen to you. The nuances you are giving while seeing the slides, and many of the features which you describe, they are not given in the text. Also, I have so many texts with me, but the
Oh,
practical tips you give, sir, it is mind blowing, and I am short of words for rendering thanks to you. And I believe all of the listeners, they will be visiting these lectures repeatedly while when they will get the cases on their desk. Too good. Sort of words, sir. Thank you.
yes.
thank you, sir.
Dr. Manoj Kahar very correctly. Many, in fact, I have been getting responses from many of the people who have been seeing slides, going back to the YouTube, listening to the thing, and then coming back and seeing the slide. So it's like it's like a textbook there, ready reference, but with certain special nuances, which of course is not present in the textbook. Agree with Dr.
Yeah,
Manoj
thank you.
correctly, right? Dr. Patania, sir, if you want to say anything.
I think.
Thank you very much. Nothing particular. I enjoyed all his lectures, and it's so fortunate to have him with me here. It's like a refresher course. He gives it to me every day. Thank you, Rajaguru.
Thank
Yeah,
you, sir. Thank you so much.
pressure course. That's true. So it's an honor. It was so nice that you were present in this gathering. So nice of you, sir, taking out time. Okay,
Yeah,
doctor. Thank
we'll
you so
always
much.
get some. Yes, sir. Fine.
It's an honor,
Thank you,
having
sir.
you with us. And we have a very important lecture tomorrow that is scheduled for Indian Standard Time 8:30, which is Dr. Sanjay Kakkar from US. He
Yeah.
will be taking on the various aspects of special liver tumors, usual and unusual. So I hope everybody joins
Yes.
in then. Yeah. Take care then, sir. Good night. Bye bye,
Yeah,
everybody.
and thanks for asking me to present this in this wonderful platform, sir. And
Oh
really
my.
nice of you for having invited me. And this has been the enthusiasm you have been showing for this particular channel has been tremendous, and putting all in your effort into it is really mind blowing. Thanks a lot, sir. And
So,
hope we meet
yeah, sure. We
sometime later.
sometime maybe.
Yeah.
Right, right. Okay then.
Yes, sir.
Okay, bye, everybody.
Thank
Good
you, sir.
night. Thank you.
Yeah.
Thank you. Bye.